Viral hemorrhagic fever, Wikipedia audio. Viral hemorrhagic fevers are a diverse group of animal and human illnesses in which fever and hemorrhage are caused by a viral infection. VHFs may be caused by 5 distinct families of RNA viruses, the families Arenoviridae, Filoviridae, Bunyaviridae, Flaviviridae, and Rhabdoviridae. All types of VHF are characterized by fever and bleeding disorders, and all can progress to high fever, shock, and death in many cases. Some of the VHF agents cause relatively mild illnesses, such as the Scandinavian nephropathy epidemica, while others, such as Ebola virus, can cause severe, life-threatening disease. Signs and symptoms of VHFs include fever and bleeding. Manifestations of VHF often also include flushing of the face and chest, small red or purple spots, bleeding, swelling caused by edema, low blood pressure, and shock. Malaise, muscle pain, headache, vomiting, and diarrhea occur frequently. The severity of symptoms varies with the type of virus. The VHF syndrome appears in a majority of people with filovirus hemorrhagic fevers, Crimean Congo hemorrhagic fever, and the South American hemorrhagic fevers caused by arenaviruses, but only in a small minority of patients with dengue, Rift Valley fever, and Lassa fever. 5 families of RNA viruses have been recognized as being able to cause hemorrhagic fevers. Signs and symptoms. The pathogen that caused the Cocolistli epidemics in Mexico of 1545 and 1576 is still unknown, and the 1545 epidemic may have been bacterial rather than viral. Different hemorrhagic fever viruses act on the body in different ways, resulting in different symptoms. In most VHFs, it is likely that several mechanisms contribute to symptoms, including liver damage, disseminated intravascular coagulation, and bone marrow dysfunction. In DIC, small blood clots form in blood vessels throughout the body, removing platelets necessary for clotting from the bloodstream and reducing clotting ability. DIC is thought to cause bleeding in Rift Valley, Marburg, and Ebola fevers. For filoviral hemorrhagic fevers, there are 4 general mechanisms for pathogenesis. The first mechanism is dissemination of virus due to suppressed responses by macrophages and dendritic cell. The second mechanism is prevention of antigen-specific immune response. The third mechanism is apoptosis of lymphocytes. The fourth mechanism is when infected macrophages interact with toxic cytokines, leading to diapedesis and coagulation deficiency. From the vascular perspective, the virus will infect macrophages, leading to the reorganization of the VE-cadherin-catenin complex. This reorganization creates intercellular gaps in endothelial cells. The gaps lead to increased endothelial permeability and allow blood to escape from the vascular circulatory system. The family Arenoviridae include the viruses responsible for Lassa fever, Lujovirus, Argentine, Bolivian, Brazilian, Chaparral hemorrhagic fever and Venezuelan hemorrhagic fevers. The family Bunyaviridae include the members of the hantavirus genus that cause hemorrhagic fever with renal syndrome, the Crimean Congo hemorrhagic fever virus from the norovirus genus, Garissa virus, and Elisha virus from the orthobunyavirus, and the Rift Valley fever virus from the Phlebovirus genus. The family Filoviridae include Ebola virus and Marburg virus. The family Flaviviridae include dengue, yellow fever, and 2 viruses in the tick-borne encephalitis group that cause VHF, Omsk hemorrhagic fever virus and Kyasaner forest disease virus, In September 2012, scientists writing in the journal PLOS Pathogens reported the isolation of a member of the Rhabdoviridae responsible for 2 fatal and 2 non-fatal cases of hemorrhagic fever in the Bas-Congo district of the Democratic Republic of Congo. The non-fatal cases occurred in healthcare workers involved in the treatment of the other 2, suggesting the possibility of person-to-person transmission. This virus appears to be unrelated to previously known rhabdoviruses. The reasons for variation among patients infected with the same virus are unknown but stem from a complex system of virus-host interactions. Dengue fever becomes more virulent during a second infection by means of antibody-dependent enhancement. After the first infection, macrophages display antibodies on their cell membranes specific to the dengue virus. By attaching to these antibodies, dengue viruses from a second infection are better able to infect the macrophages, thus reducing the immune system's ability to fight off infection. Definitive diagnosis is usually made at a reference laboratory with advanced biocontainment capabilities. The findings of laboratory investigation vary somewhat between the viruses, but in general there is a decrease in the total white cell count, a decrease in the platelet count, an increase in the blood serum liver enzymes, and reduced blood clotting ability measured as an increase in both the prothrombin and activated partial thromboplastin times. The hematocrit may be elevated. The serum urea and creatine may be raised, but this is dependent on the hydration status of the patient. The bleeding time tends to be prolonged. With the exception of yellow fever vaccine, neither vaccines nor experimental vaccines are readily available. Prophylactic ribavirin may be effective for some bunyavirus and arenavirus infections. VHF isolation guidelines dictate that all VHF patients should be cared for using strict contact precautions, including hand hygiene, double gloves, gowns, shoe and leg coverings, and face shield or goggles. Lassa, CCHF, Ebola, and Marburg viruses may be particularly prone to nosocomial spread. Airborne precautions should be utilized, including, at a minimum, a fit-tested, HEPA filter-equipped respirator, a battery-powered, air-purifying respirator, or a positive pressure-supplied air respirator to be worn by personnel coming within 1,8 meter of a VHF patient. Multiple patients should be cohorted to a separate building or a ward with an isolated air handling system. Environmental decontamination is typically accomplished with hypochlorite or phenolic disinfectants. Medical management of VHF patients may require intensive supportive care. Antiviral therapy with intravenous ribavirin may be useful in Bunyaviridae and Arenaviridae infections and can be used only under an experimental protocol as investigational new drug approved by the U.S. Food and Drug Administration. Interferon may be effective in Argentine or Bolivian hemorrhagic fevers. The VHF viruses are spread in a variety of ways. Some may be transmitted to humans through a respiratory route. According to Soviet defector Ken Alibek, Soviet scientists concluded China may have tried to weaponize a VHF virus during the late 1980s but discontinued to do so after an outbreak. The virus is considered by military medical planners to have a potential for aerosol dissemination, weaponization, or likelihood for confusion with similar agents that might be weaponized. Causes: Pathophysiology, Diagnosis, Prevention, Management, Epidemiology. Biowarfare potential.